Welcome, everyone. We're so glad that you're here. My name is Mary Maeda of Canine Cancer Alliance, a nonprofit foundation focused on research and education. We're an organization led by volunteers, and our mission is to end dog cancer as we know it today. So we can have safe and effective treatments that are also affordable and could become widely available for dogs. And the work that we do is made possible by donations from individuals and families who love dogs. So if you find this webinar and the videos helpful, please visit our website and consider donating. So today we are really excited to have as our guest Dr. Brian Flessner. Dr. Flessner is going to describe a new treatment strategy that's very promising. You've probably heard me and others talk about the importance of combination and multi-pronged approach to stopping cancer. Cancer is smart and uses many different tricks to survive, and it can draw in immunosuppressive cells and create a protective microenvironment around itself. It can even turn off killer T cells. So you need multi-pronged attack strategy. Now, if you joined the webinar this week with Dr. Guanang Wang from Vetomics, she also talked about the need for multi-pronged approach after doing comprehensive genomic profiling and finding targeted therapy. So just one targeted therapy might not be effective, but if you combine them, it might be much more effective. In this exciting clinical trial that Dr. Flessner is going to describe, it's actually backed by a company called Ardent Animal Health, and it's evaluating a new combination approach that hopefully will help more osteosarcoma patients survive for a very long time without metastasis. The trial is open now, and quite a few hospitals are actually participating in the trial. And so here is Dr. Brian Flessner.
Thank you. Thank you very much. Okay, so I think slides are showing. I'm going to advance and just make sure that's true. I'll start with conflict of interest. I am paid by Ardent as a project manager for this trial. It's an initial study to gain USDA approval. And so this is standard of care versus the novel immunotherapy approach. My other conflict of interest I have up here is a little bit of a funny, but I also still help my family part-time on the family farm. So there's me with row crops and cattle that we raise too. So the outline I'll talk about today, we'll first do a little bit, Mary, you talked about the immune system and the multimodal approach that's usually necessary. There is no silver bullet, it seems. So we'll talk about the hallmarks of cancer, key components, antigen presenting cells and T cells, and then kind of the crux of this talk, immune checkpoints. I'll really briefly talk about veterinary approaches to cancer immuno. I'll talk about a couple of the commercially available vaccines versus the new immune checkpoint inhibitor that we have available, and then a little bit about osteosarcoma, where we're at, the studies we've done recently with immunotherapy, and then we'll jump into the study and Ardent's background info. So we'll start with the hallmarks of cancer. Cancer is like you talked about, a complex disease process of pretty much about any cell in your body. Hanahan has had a few iterations of this. This is the newest hallmarks of cancer. When I first read this, I think there was originally 6, and then he upped it to 10. And so when I was studying to be an oncologist, I had to start with 6, move to 10, and now I think we're up to 14. Short story that I'll summarize is the immune system is really important. And so there is kind of 2 pillars, if you will, of the immune system with cancer. Of cancer cells have to be able to, a hallmark of their ability to live is to avoid immune destruction. And the second is that inflammation can promote tumors. We always think about chronic inflammation in your body, but then also, Mary, you mentioned this, if you have immunosuppressive cells that actually promote tumors. So just to show everybody that when we think about all the other things that cancer cells gain and do, their interplay with the immune system is really important. This figure is a little bit of kind of a flow. I don't know. I liked kind of the images from different spots, and we'll just talk about how do things show up to the immune system. So when we talk about cancer, it truly is a genetic disease. You could say cancer is genetic and epigenetic, but the epigenome is part of your genome. So when you think about the cells in a body, and this is from Chibuk, Andy Flory et al., and Frontiers. We think about the cells of cancer or other tissues in your body. They're in chromosomes. You unwind those chromosomes into DNA, you go through histones, nucleosomes, and eventually you get down to our DNA double-stranded helix with our ladder of 4 base pairs. Those base pairs, and Gwenon might have talked about this too, about mutations and how you target those things. But that DNA code can be mutated through endogenous or exogenous factors. And so endogenous things could include reactive oxygen species, maybe from inflammation. So you could have tumor-promoting inflammation or chronic inflammation that causes mutations in your DNA that then would be damaged and lead to cancer, or exogenous things, especially we humans do to ourselves, smoking, drinking, sunbathing, all sorts of things that we do, whether or not it's for fun, but that can lead to mutations that can cause cancer. And so whether it's from inside your body or outside of your body, you damage your DNA through, we'll just kind of use a big word of mutations, and that can lead to cancer. How does that show up in a cell? There's a few ways. And so this is a little schematic from the Society of Immunotherapy. So you can actually have too many self-antigens, and so that actually can promote a cancer. It's not necessarily a mutation, but more like you could think of an amplification or some sort of other overexpression. And so the best example I can give you is HER2 and breast cancer. And so women with HER2 positive tumors have much more HER2 on their surface. It seems to be a fast growth pattern, but then is targetable with anti-HER2 therapies. You can actually have viruses that can cause mutations, and they'll show up in cancer cells as what we call antigens. So these antigens are usually, not always, but usually pieces of peptides or proteins that are displayed or present in a cancer cell. And that's your immune system's job, is to say, hey, that's mutated. So usually the immune system isn't going after mutated DNA. It can, but it's usually not. It's going to go after the downstream effect of these peptides that are shown on the surface or in the cell cytoplasm. You can have these mutated self-antigens, and I think that's what most of us like to think of as the easier target. So if you have DNA mutation, it leads to these antigens, usually proteins, like I said, that are going to be expressed, and those could be targeted. You can also get different oncogene products, and that might be 2 genes that shouldn't be next to each other that fuse. We call those fusion proteins when they come out as proteins. But just to show that there's different things in the cell, mainly proteins we think about, but could be DNA or RNA as well, that the immune system will say, hey, that seems abnormal. I probably should check that out, and then hopefully remove it so it doesn't turn into more cancer. So who are those key immune players? There's a bunch of cells in your body that their job is to survey your cells, your blood, and just to keep you healthy and free of disease. The main players that we're going to talk about for this study, there's many, many here, but I don't have time to talk about all of them, are CD8 positive T cells. So those are the cytotoxic killer T cells that Mary also mentioned, and then dendritic cells. And dendritic cells' main job is to chew up antigens, whether it's from cells or from dead cells, kind of in the environment, and display those to the rest of the immune system. You'll probably see other cells on this Venn diagram. We think about antibodies from B cells, we think about NKs, natural killer cells, whether those are natural killer or natural killer T cells. And so there are a lot of players for both innate and adaptive immunity. I'm just going to talk mainly about these 2. And the reason we talk about these 2 is this is actually the main way we get communication with the immune system to go kill. And so on the left here is a dendritic cell. On the right here, we're going to say that this is actually a cytotoxic T cell, a CD8 positive cytotoxic T cell. This dendritic cell's job is to eat and chew up antigens that it comes across, those abnormal proteins or other things. Could be viruses too, that it comes across in your body. When it chews up those, whether abnormal or could be normal antigens, it displays them on its MHC. And MHC is really unique to antigen-presenting cells. There's a couple different types of MHC, but also it's present on any cell in your body. So if you get interaction between a dendritic cell and a T cell, that actually can then, that T cell could say, hey, I recognize that MHC. I think it's probably on other cells too, and it'll go around and look for this little red antigen. Let's say this is the mutated protein that's displayed by this dendritic cell. This CD8 positive T cell says, ooh, I recognize that too. Now I can go lock onto that antigen in other places and potentially kill those cells. If it were only that easy, maybe we could kill cancer better, but also you'd have a lot of autoimmunity. And so there's other checks and balances on the immune system so that you don't just say, oh, I see this protein everywhere, let me go kill it. And so this is MHC class 1. So I think up here on the sidebar, you'll see the different color codings and what those mean. And so MHC class 1 is a normal receptor on an antigen presenting cell. It binds to CD8 positive T cell receptor. And so these two together would say, we have a match. This looks like an abnormal antigen. Let me go do something about it. Well, to do something about it, you also have to have co-stimulation. And so on this antigen presenting cell, you see the CD80 and it binds to CD28. That co-stimulatory signaling is necessary for this T cell to say, I can go on and kill other things. The other thing up here you'll see is number 3 is there has to be cytokine production to keep that T cell and then others that it'll recruit activated. And so excitation with either paracrine or maybe even autocrine cytokines. So that means like there's cytokines in the environment or these cells are giving them to each other, keep those cells activated to go kill. And so it is kind of this, we show 3 steps, but there's many things that you can do to promote or inhibit the immune response. Over here, and I didn't show a lot of these, but you can also see you can block these factors. And so the best example is usually PD-1, PD-L1, and I'll show some schematics of that. And that's where I think most of the commercials anyway for human medicine have gone as to PD-1 inhibitors or PD-L1 inhibitors. CTLA-4 is another immunosuppressive factor. It actually binds CD80. So if you can imagine, actually, if you turn this into an inhibitory signal, you block that co-stimulation completely. And then I'm sure people on here have heard about LAG3 inhibitors. Those can actually go after a separate MHC class receptor, MHC class 2, that also is on antigen presenting cells and block it from binding its T cells.
Right.
And so,
Brian?
yeah.
Can you use this graph and just point out which ones this clinical trial, this therapy is addressing?
Yeah, so we're actually giving antigens from tumor cells, and so it'll be this little red dot that would be MHC on MHC class 1 or class 2 that would go to a T cell, and then the CD200, and we'll go through that schematic a little bit later, is going to kind of ramp up this cytokine release. There are studies that are looking at step 2, that co-stimulation, but that is not part of this study. Yeah.
So on the right-hand side, you
Uh-huh.
have PD-1
Yeah.
and CTLA-4, and the checkpoint inhibitor you're using is addressing both PD-1 and CTLA-4?
That's the good question. So it's separate. It's a completely separate process. So in theory, we'll have to see. I don't know about safety for that. Is could you use it with other immune checkpoint inhibitors? And so in human medicine, especially melanoma, they're actually looking at dual immune checkpoints blockade. And so with different either PD-1, CTLA-4, different mechanisms. And so CD200, also known as OX2, is the checkpoint inhibitor in this study. And I don't have it in this schematic because it's relatively new. Yeah.
Thank you.
But it would be in these checkpoint inhibitor categories. Yeah.
Okay.
Good question. So actually, I lied to you. It's not in this schematic, but you could see it as a 2 marker here. So you would have 1, 2, and 3 with the, and we'll talk about those things. But yes, the vaccine itself that we make is a 1. The checkpoint inhibitor would be 2, and it blocks cytokine production. So you have a 3. And so we'll talk about those 2 things. So first, I'll talk about normal checkpoint inhibitors. So the PD-1, PD-L1s. So if you think about a tumor cell, it can actually express these, in this schematic, I showed the dendritic cell, which is your antigen presenting cell with a T cell. Tumor cells can take advantage of all of these different things. And so they can do lots of stuff just like an antigen presenting cell could do. So in this one, you actually say, here's a tumor cell, here's its MHC class 1 that binds this CD8 positive T cell receptor. We have a match. This T cell should kill that tumor cell if there's enough cytokine release and activation. And so what the tumor cell does is it puts PD-L1 on its surface, which binds PD-1, and that we kind of call a don't eat me signal. And so that way it actually blocks co-stimulation, and that T cell will move on down the line and go kill other things, hopefully. And so tumor cells kind of hijack that don't eat me signal. So what you do is you actually can give checkpoint inhibitors like anti-PD-1 or anti-PD-L1, pembrolizumab or Keytruda, I think is the most commonly known one. That's that red triangle. You put that in there, the T cell now says, go ahead and put PD-L1 on your surface all you want. I have my lock on that antigen and I'm going to kill. And so this is a really kind of basic schematic of checkpoint presence and then checkpoint blockade, if that helps. Any questions there then, Mary or anyone else?
Well, that's good. Thank you.
Yeah. So CD200, OX2 is
So just sorry, Brian.
yeah, that's
I
cool.
just wanted to point out to the audience that PD-1 checkpoint inhibitor is available for dogs now. There's a
Yeah.
conditionally approved product called gilvetmab, and veterinary oncologists in the U.S. can provide it to dogs. And so, yeah, that is an option that's available now.
Yeah. We have a slide coming for that too. That's a good plug for a later slide. So CD200 OX2 is the pathway that we're looking at in this clinical trial. CD200 is normally present on, you guessed it, dendritic cells. So you see these DCs up here, but also other cells in your body. And then cancer cells can use that as well. CD200 binds at CD200 receptor, which usually is on B and T cells. And so you kind of see that same interaction, dendritic cell, T cell. And so cancer cells can take advantage of that as well. When those two bind, CD200 to CD200 receptor, downstream signaling is usually through the RAS-RAF pathway, and it actually blocks cytokine release. And so we need cytokines. We showed that in that first schematic to excite the immune system and to keep things active and going. And so if you block that downstream cytokine signaling, none of the cells are activated, and you might get a match, but not actually a potent kill. And so this schematic here on the right then just shows CD200 is now hijacked, if you will, by a tumor cell. It binds to CD200 receptor on a T cell. There is now no production of cytokines, and so this T cell is not activated, doesn't want to kill. The other thing that CD200 can do is it can actually promote myeloid-derived suppressor cells. You kind of mentioned this too, Mary, and tumor-associated macrophages. And those are potently immunosuppressive and kind of keep the whole environment quiet. And so activation of this pathway prevents cytokine production and then prevents the rest of the immune system from kind of playing tumor kill. And so you can actually then promote invasion and metastasis if you block those, or if you promote those TAMs and myeloid-derived suppressor cells. So, sorry, this is a really small little graph, and to fit it on this, I broke them into little chunks, but now let's move to what do we do in veterinary oncology right now with immunotherapy. And so this is some stuff that we were working on in Missouri while I was at Penn, and now actually there was some really exciting stuff out of Leah Labs in dogs with lymphoma, where they're actually showing some responses with CAR T cells. There's a lot of CAR T research in vet med. It's available especially in people for lymphomas and leukemias, but CAR T cells are actually then engineered T cells. They have this CAR as the chimeric antigen receptor, and so that's actually the edited version of a normal T cell receptor. And those CAR Ts then are able to go find those red circles, those antigens, and kill anything that they find with those. So CAR T cell therapy, big in human medicine, people keep trying in veterinary medicine. The second thing is, what if you just give cytokines into the area? And so this one shows that there's some anchored cytokines. I think this was Tim Phan's group that looked at actually anchoring those cytokines, like interleukin-2, which is I used T cell crack once and it kind of stuck with me, haunted me now from my students, but it actually really ticks off T cells, makes them kind of crazy. And so interleukin-2, you can anchor it to cells and kind of get the immune system activated around it. And they've studied that in canine melanoma. Cancer vaccines, which is another part of this clinical trial, have been used since the dawn of immuno-oncology, and that's actually where you process or do something to the tumor cell to show neoantigens or new things. This is actually one of the steps in the alliance cancer process, and so you make a vaccine out of that cancer and its cells, which should then hopefully excite T cells and then go move to the rest of the body where there are other cancer cells that are hiding. And so here again, you have your dendritic cells showing this T cell, this neoantigen. And the last thing, and we've also talked a little bit about this, is immune checkpoint inhibitors, Keytruda, pembrolizumab. Our version is gilvetmab, which is just conditionally approved by the USDA. And so this is the blocking the don't eat me signal. And so that schematic I just showed, PD-1, PD-L1, you actually give an antibody to PD-1 or vice versa. And now you actually don't have the brakes on the immune system. So just to show you some of the ways that we're fighting this in vet med. If I say then what are some approved for immunotherapies in veterinary medicine, the first one to talk about are mainly for melanoma and for mast cell tumor. And then, and Mary, you had asked me to mention this, but Elias, and I'll be in one of my other slides, just got full approval by the USDA for their multimodal approach with T cells. So the first one, Oncept, this is a human DNA vaccine. So this is actually, we say xenogenic, but it is a different species. So we're giving dogs human DNA, which is pretty cool. This was developed at Memorial Sloan Kettering with Phil Bergman and some MD folks at MSK. And so this is just a schematic of what the DNA that we're giving is. It's in a plasmid, and you can actually see the tyrosinase gene. This is human tyrosinase we give to dogs. We give them the gene. There's some really neat science that hopefully then they downstream show up making human tyrosinase protein. There's a potent promoter on this to really ramp up those plasmids and make them make a lot of tyrosinase. They've looked at immune responses, especially humoral, which this means B cells and antibodies. Again, we want T cell responses, and so this is a kind of a, I guess you could say, a proxy of immune response. They did note antibodies to human proteins in 3 out of 9 dogs. The approval study for this actually went through the FDA. This would go now through the USDA, but they actually looked at dogs with stage 2 or 3 melanoma. They compared to historical controls, and I think you can see these curves are Kaplan-Meier curves. Every time the curve drops, a patient passes away from cancer. And so you can see in this curve with the vaccine, less patients passed away than in this curve. And so this actually led them to get full approval. There is controversy like any therapy. Many oncologists, including myself, use this. The side effect profile is really low, but there is some other questionable data that's out there that's not prospective. Again, the controls here were historical, but this is fully approved for use in canine melanoma. We've used it in cats, horses. I've treated quite a few horses with this vaccine. I've heard of people using it in seals, all kinds of different species. Again, because it is human, so any non-human species, you could, in theory, hopefully get an immune response. Gilvetmab is our conditionally approved monoclonal antibody against PD-1. This is out of Merck. The Oncept is from Boehringer Ingelheim. And so this actually hasn't been published. There's only really been presentations on the initial study. There was stage 1 through 3 mast cell tumors, and then stage 2 and 3 malignant melanomas. We have a dosage in this. You can get every 2 weeks for up to 10 treatments. It's quite expensive right now. I'm hoping that will come down in the future. They had a decent response rate in mast cell tumors, about a 20% response rate, and that's actually shrinkage of tumors in melanoma. Initially, there were some dogs that had severe anaphylaxis, which I always say that you want some small immune side effects, but not so much that you are sick enough for pass from the therapy. And so they did have some dogs that had pretty wicked immune side effects that exited the trial. We pre-treat with Benadryl, and we always watch and have steroids in our pocket if the immune system goes too wild. And I've actually started using this in my practice. Right now, the biggest thing is it's a little cost prohibitive, especially with big dogs. You can go through a lot of these vials. It is special order only through oncologists, and we actually have to go through some hoops to get it for our patients. But it is a nice option that's similar to Keytruda in people. So this little schematic, I just put in gilvetmab instead of pembrolizumab. If we move to osteosarcoma, what we do standard of care wise, and I think a lot of us are frustrated with this, is amputation and chemotherapy. And so we did this really large prospective randomized study with the NIH, myself, Jeff Brimer, a couple of the authors at the University of Missouri, and we looked at what does standard of care actually give you. This was funded by the Morris Animal Foundation and was a supposed to be 5-arm study. They ended up funding 3 arms, and then I think stopped funding these efforts. I'm sure many of you have heard of Listeria. That was a 3rd arm of this study, but the first one was standard of care versus standard of care plus rapamycin. And anyway, we did not find an improvement when rapamycin was added to these dogs, but we did have a really nice prospective cohort of dogs getting standard of care. The old studies show about survival times between 10 to 12 upwards to a UC Davis study that showed maybe like 18 months where you have amputation and chemotherapy. The best survival was 6 doses of carboplatin. And so that's something I talk to my clients about is let's check for evidence of spread at 4 doses. And then the most information we have is if we can get to 6. This standard of care study, the highest level of evidence that we have was only 4. And so this is the Kaplan-Meier curve for that study. You can see the red versus blue here overlap, and so there was no difference in survival of dogs that got amputation and 4 doses of carboplatin versus amputation 4 doses of carboplatin and rapamycin. So we were frustrated with that, but it was really good data for us to say this is what we do now and how can we improve that. If you have dogs that don't qualify for standard of care, which usually, not always, but usually is an amputation. Sometimes we can do limb spares depending on the tumor location. But non-surgical dogs, we'll talk about radiation therapy, bisphosphonates, and that's some research that Tim Fan has done in Illinois and I did when I was at the University of Missouri. And then we do also describe medical management for those dogs that can't have any of those therapies. Where are the numbers for immunotherapy in osteosarcoma specifically? And so I kind of mentioned the survival times of 10 to some people show 18 months if you can get 6 doses of carboplatin in. But really, I think most of us are leaning now towards just showing disease-free interval. How long do we keep dogs in remission after an amputation? And so we had a disease-free interval of 6 months in that prospective standard of care study with Amy LeBlanc and the rest of us with the NIH. And so that was 157 dogs prospectively. All of them were treated the same. If you look at the rapamycin dogs, their disease-free interval was only 6.8 months. If you go back in time, this is actually when I was very, very young, barely born. Greg McEwen at Wisconsin actually looked at amputation plus LMT-PPE. MEPACT is the brand name for that. It's only available in Europe right now. Their disease-free interval in dogs that had just amputation and that sole immunotherapy, which it's a bacterial cell component from like mycobacterium, like the cell wall, and so it is a pretty potent pro-inflammatory therapy that actually makes you make a lot of cytokines. And so anyway, dogs that got amputation and that immunotherapy had a remission of 6 months, just placebo alone. So if you just gave them saline or another placebo, their disease-free interval was 2 months. And that's what most of us will say is like, yeah, if we don't do any chemotherapy or anything, they do succumb to disease pretty quickly. It's really rapid metastasis. McEwen's group followed that up with another study where they actually looked at sequential. And so, Mary, when you talked about needing multiple modes of therapy, I think this is older information that says, yes, that is necessary. And so they looked at actually cisplatin, which I do think is a better drug than carboplatin. It's just tougher to give for these dogs with osteosarcoma. If you do amputation, cisplatin, and LMT-PPE, their remission duration was 11 months, which is longer now than even the survival times we get. Their survival times were even better than this. And so they looked at that sequential, not concurrent, so back to back, not at the same time. When they did cisplatin plus placebo, they still got around that 6-month mark, which here was 7.6 months. And you can see then the next line they did concurrent and there was no improvement. Go down a little bit, you'll see other studies here. The Laura Marconato's group out of Italy actually looked at carboplatin plus a salmonella peptide, another ACV or autologous cell vaccine. They had improvement based on carboplatin alone. And then if you actually go back to the study I wrote out of Missouri with Jeff Bryan, the initial Elias study, we actually had a disease-free interval of 7 months with immunotherapy alone. And so the only immunotherapy alone disease-free intervals we have would be McEwen's up here at the top, and then ours at Mizzou. The rest of these are mainly combination therapy. So we just published this Listeria study with amputation, 4 doses of carboplatin, and listeria, we only got 7 months. So no real improvement based on standard of care alone. Again, that was 6 months.
So,
So I think when we talk about remissions, we want to do much better than 6 months. Survivals, we want to do better than a year. And I think it then goes to, you have to look at what kind of combo therapies can you give. I'll be quiet for a minute if anybody has questions.
anybody who has questions, please, just small number of us. So you can chime in or drop them in the chat. Or I actually have some questions. Um,
Yeah,
Immunocytin is actually quite similar. It's a bacterial extract,
yeah,
right? And
yeah.
there hasn't been really great data published yet, but
No, there hasn't.
anecdotally, we do hear some dogs surviving longer with the help of immunocytin, especially IV infusion of immunocytin. Have you had an experience using immunocytin?
Yeah, that came out when I was a resident, so back in the early 2010s. It was labeled for mammary tumors. I gave a little bit of it during my residency. I will tell you, it didn't seem to promote immune reactions like we'd want. And really, then the company never did follow through on the additional studies. And so, like you said, there really isn't good data for it. Anecdotally, I can tell you the cases I treated with it didn't have at least memorable outcomes in a good way. And so, I think it is an option. The science there is a little bit lacking. They just haven't published anything. It has not had a big prospective study behind it either. It's really, we gave this to some dogs and they seem to do well. So I don't think it's, I don't think it's a bad product, but I don't know as a sole therapy that it's going to do much, especially for solid tumors like osteosarcoma. Yeah.
When you used it, were you using it intratumorally, like it says on the label, or were you doing IV infusion?
Yeah, intratumorally. And I think I did it in mammary tumors. Haven't given it IV in a long time. And that was, like I said, probably almost 15 years ago. Yeah.
So the other comment is LMTPPE, muramyl tripeptide. So
Yep.
this is available as a human pediatric osteosarcoma drug in Europe. It was only approved in Europe. It never got approved in the US for some, I think, stupid bureaucratic reason. But you
Yeah.
can get it for compassionate use. So we looked into it to see if we can help make it available for dogs. And it is expensive, whoever the vendor is, it's quite expensive.
Yeah.
But it is possible to order it for research in the US, and it's not that expensive. It is quite affordable. So I think at some point it's, depending on the outcome of this trial, it might be a something that we should try to look at again.
Yeah, yeah, no, I think you look on this chart and you can see that is the best if you add chemotherapy with it. And again, these aren't head to head, so we can't just say all of these are comparable to each other.
Mhm.
But most of them did have a control group, and usually that was chemotherapy or placebo alone. And so, we have always known that LMTPPE was beneficial to both dogs with hemangiosarcoma. It's the best survival times we've ever seen with hemangiosarcoma and osteosarcoma. Yeah, unfortunately, it's just not available for us here. It's standard of care for pediatric osteosarcoma in Europe. Yeah, we've been frustrated and talked about it for a long time of why we missed out here in the States. Yeah, I don't know. It'd be good to push some people again to let us have it, especially if it was affordable. It would be nice to add with other therapies. Agreed.
Right. Okay. And then it would be great if this chart also includes Listeria vaccine and
Yeah, it
the Yale
does.
vaccine.
Oh, the Yale vaccine. Yeah. So if they'll publish it, I'll put it on here. So I don't have a publication yet to put on here for that. So it would
Okay.
go on here
We'll, we'll
if we had
send
to.
you some.
Yeah.
And the Listeria vaccine has had a number of publications, so
Yeah, and
after
so
the
this is
initial
actually the
study. So,
COTC. Yeah, this is the COTC 26 study, and so this is standard of care plus listeria. We did that. Nikki Mason led that out of Penn. I was an investigator at Missouri. We just published that earlier this year in 2025. So her initial study was a single arm, no control. So if we look at background of the Ardent vaccine, this is a live cell vaccine. And so I do remind people, especially when we're training sites to enroll cases, that these need to be alive. Live cell meaning when the tumor is sent off to Ardent's lab, they collect it, cells have to be viable. And so if you have really necrotic tumors, if there are things that are done to the tumor beforehand, They can't make the vaccine how they want to. And so they create neoantigens. We talked about that early on in the talk about the different antigens and how those are recognized by the immune system. And so this is neoantigens via UV radiation. They have a really beautiful lab in Lexington, well, outside of Lexington, Kentucky. So those cells are radiated, they undergo immunogenic cell death, and their primary adjuvant. And so this is actually, I guess you could say, kind of similar to LMT-PPE, maybe immunocytine, but is a oligodeoxynucleotide called CpG. This mimics a bacterial adjuvant and does excite dendritic cells. It makes them stimulate interleukin-2 and interferon gamma release, and then hopefully also co-stimulatory factors. They've now, I need to update this, I always say that, but they're well over 2,000, I think maybe even in the thousands of dogs that they've vaccinated. Their adverse events with this alone, so vaccine plus primary adjuvant, is local irritation, swelling, and fever. There haven't been major systemic side effects noted. Their internal data for survival, you can see here, and this is vaccine alone. So this isn't combination with other things, and it doesn't include the checkpoint inhibitor that we're doing in this study. But they have some nice data, especially in hemangiosarcoma, where dogs didn't get chemo. They just had splenectomy and this vaccine, also a mast cell tumor as well. And they have some anecdotes of, I think, a mammary tumor and a mast cell tumor where they showed regression of those tumors when they were still on the animals. The proof of concept study for this was actually in immunology and immunopathology with Raylene Woda at K-State. And they showed that 85% of dogs that got their own vaccines could develop IgG, so another antibody response, and they looked at that with Western blots. And so that's up there in the corner. Dr. Iannelli was one of the original scientists with Dr. Cohen, and then Raylene Woda at K-State. So that's where the original science for this comes from. The second
Oh,
part is
sorry.
the,
Ca-
yeah,
Sorry, can you go back to that slide, please?
yeah, for
Um,
sure.
so the hemangio, I've never seen this data with hemangiosarcoma,
Yeah.
median survival time 181 days. Do you
Yeah.
know what stage hemangio patients
Yeah,
are at?
so this is a collection of hemangiosarcomas. Usually would be stage two. I don't know if stage threes are involved in here too. Some of this data, it's internal, and I will tell you, it's a lot of general practitioner data, and so staging is not as I don't want to say not as complete, but often not standardized as it would be with oncologists. And so, a grain of salt, that is just hemangiosarcomas. I don't have, they're not all the same stage,
Okay.
but
But it's splenic, or does it include
well,
subcutaneous, or
yeah, clinic. Yep,
okay,
yep.
okay.
Good question.
And can you say something about availability of just the Ardent, um, the autologous
Uh,
vaccine currently?
Well, you could use it commercially, and there was a lot of veterinarians around the country that were using it commercially. We actually, before the study opened for osteo, I had used it in a couple of dogs with osteosarcoma in the commercial setting, doing either concurrent or sequential chemo immunotherapy. Um, the experimental license for a few vaccine companies expired at the end of, I believe, June. And so currently you are unable to get it for commercial use. So the only way to get this vaccine right now, again, this is the vaccine does not include the checkpoint inhibitor, but with checkpoint inhibitor is in the osteosarcoma study. And Adrian Wright, who's the main sponsor representative at Ardent and I, are working on some hemangiosarcoma options, but that'll have to be studies as well. So commercially not available, unfortunately.
Do you know if a family wants to appeal and see if they can access the vaccine under compassionate use from Ardent?
So the I know the USDA's stance on experimental therapeutics and the window they give people to research it to get approval. I know that they're, I think, excited about the progress we're making in the clinical trial already. But the stance would be is that it's not for sale for commercial use because of the license expiring, and so only now in studies can you get it available. So I would tell people that if their dog has osteosarcoma, to see if they qualify. There's clinics all over the country, including in the Seattle area, where they could be screened and try to enroll. But for sale commercial use is prohibited from the USDA right now. Yeah,
Okay. They
yeah,
can't sell it, but
yeah.
But compassionate use is a little bit different because they won't
Yeah,
be selling
I'll
it
be.
as
I'm gonna. I'll be quiet
antibody.
there. I don't want to get in trouble.
Okay.
Yeah.
All righty. Thank you.
Yep. Yep. You're welcome. So the CD200, there is a list. I see that real quick. I saw it pop up. I have a link later on in the slide deck of all the different clinics around the country, but it is coast to coast, really. So CD200, the peptide is CD200 ARL. That's actually the name of the checkpoint inhibitor. This is a busy slide. The biggest thing is that it does upregulate a couple of those cofactors. We talked about CD80 and 86. It makes cells produce more cytokines, and it does make those dendritic cells, those antigen-presenting cells, work better. So it enhances their differentiation. There is some work, and this is out of Mike Olin's lab at the University of Minnesota, that it might actually downregulate PD-1. So could it do like a double checkpoint where it does its own thing and then actually downregulates PD-1 and PD-L1 on tumor cells? That remains to be seen. But right now, we do know that the biggest thing is it enhances cytokine production and then potentially upregulates cofactor expression, maybe also downregulates PD-1. And so you can see a few of those things here: PD-1, PD-L1, CTLA4. They just have kind of everybody up here, but mainly, again, enhancement of cytokines. The clinical data where this has showed the most promise, and I think where we're really excited about this, was out of the University of Minnesota, and they looked at dogs with glioma. And so dogs with glioma, pretty terrible brain cancer, really terrible survival times. We just don't have anything that really works. And so they looked at dogs that had their tumors removed with their autologous vaccine alone. And this is median survival time, not disease-free interval. So how long did those dogs live? You can see, even though the median survival time is about 6 months, almost every dog died right around 6 months. And so really no benefit of just a vaccine alone. When they added the CD200 peptide, I think you can see a very different curve here, is that many more dogs lived, and the median survival time in this group was actually over a year, which is pretty unheard of in glioma in dogs. The safety profile, and this included a neurologist, some basic scientists up in Minnesota. They did say some dogs developed leukoencephalopathy, is kind of swelling of the white matter of your brain. That responded to corticosteroids, and so I tell people I don't think that brain swelling is a normal side effect of this therapy for non-brain tumors. I think that makes sense if you think about the immune system infiltrating the brain and then causing swelling from inflammation. But it does make me think about that if you have cancer cells hiding other places and this does excite the immune system, you could get swelling inflammation in those. And so, we always talk about lung metastasis with osteosarcoma. And so we think about, could we see pneumonitis? Could we see pleuritis? Could we see more extensive cytokine release syndromes? And so they said dogs did really well, but just a note that we do have to watch for immune side effects anytime we give immunotherapy. But pretty promising data out of Minnesota originally. So we use that data with the
Brian,
Ardent. Yeah,
sorry to interrupt again.
no, it's okay.
How is the peptide given? IV infusion, injection? Can you compare
Yeah,
it with Gilvancab?
yeah. So it's intradermal, and I have a video to show how it goes. So it's really easy. It's actually just through the skin, like a TB test. Yeah.
Is it multiple times? Do you have to come in every week, or is it just one or two shots?
So they get a priming dose the day before their vaccine. And so we put it between the shoulder blades. They'll get a dose as a priming dose, and that's to activate those dendritic cells the day before. And they'll come back and get a second dose the day of their vaccine. We repeat it every 3 weeks to match the chemotherapy administration cycle. So 2 back-to-back visits, and then every 3 weeks instead of every 2 like Gilvancab. Yeah,
Thank you.
good question. So this is a consort diagram of how the study is designed. We worked with a statistician to do this, Dr. Fan, myself, and a statistician. It was kind of fun for me. I'd not ever done a non-inferiority study before. And so the goal is we'll assess dogs for eligibility. Excluded dogs would include dogs that don't have osteosarcoma. Remember, we said it has to be a live cell vaccine. So if we can't make a vaccine, there's no study for those dogs. If they're on other immunomodulators, so if they're on Gilvancab, if they're getting Librela, if they're getting other cytopoint apical injections, those immune modulators would exclude them, or if they've had any previous treatment for their osteosarcoma. Again, we need those cells to be alive. So if dogs don't have any of those exclusion criteria, they're randomized to either get immunotherapy, which is the autologous vaccine with the primary adjuvant, and then the checkpoint inhibitor, and that's 45 dogs. This is a 3-to-1 randomization scheme, or they'll get 4 doses of carboplatin. We combined so that we could do concurrent controls with historical controls. So you could say a small cohort of prospective dogs, because we do know that chemotherapy alone does not cure dogs. And so we kind of combined these two groups of the original COTC22 study, which I showed earlier, with a small cohort of dogs in this arm. And so the study is designed identically to that for screening and for follow-up. And so, we have, I think, a really highly powered study to try to see if we can achieve non-inferiority. If dogs have progression on the immunotherapy arm, they're allowed to go forward with any therapy they want off study. And so a lot of people talk about the losartan-palladia combo out of Colorado State. That's an option for them if they do have progression. If dogs progress on the chemotherapy arm, again, it's only 15 dogs, but if any of those do progress, they do have a vaccine produced, and so we can give their vaccine to them, compassionate use in the study. But again, not, you mentioned this already earlier, Mary, not commercial use. So that is the concept diagram of our study design. Inclusion exclusion criteria: dogs have to be over a year of age, over 20 kilograms, and that's to match the COTC22 studies. They have to be in good health, and so people always ask me this. This always comes up with cancer. What if you have more than one cancer? And so 2 cancers is exclusionary, unless you had one that was previously cured with another therapy. They have to have confirmation of their osteosarcoma, and they have to have a vaccine produced by Ardent. Exclusion criteria, we already mentioned this, but previous therapy, immunomodulators. We're really careful with NSAID treatment, and so any non-steroidals that are given around the immunotherapy are excluded, and that's because we don't want to suppress the innate immune system. And then kind of standard things, they can be pregnant, lactating, or participating in other studies.
Mm-hmm.
Study schedule.
How is it confirmed? How is the diagnosis? Could it just be imaging, or do you have to have had biopsy?
Yeah, so we don't have to have pre-amputation confirmation of a diagnosis. Currently, what we're doing is if clinics do want to confirm osteosarcoma before amputation, that's fine. But we try to keep people from biopsying these tumors, because then you could say you have more likelihood of a necrotic tumor sample that then you couldn't grow or couldn't collect a live cell vaccine. And so they all are confirmed on histopathology after vaccine preparation by Ardent. So we are right now going off of usually signalment, tumor location, radiographs, but they're all confirmed with histopath after their amputation.
So in future, not this trial, but if this trial is successful, and in future, if a dog cannot get amputation surgery, they're not candidate for surgery, could a doctor biopsy enough, remove enough sample to create the vaccine with?
Osteosarcoma would be tricky, but there are people looking at cementoplasty. So in theory, if you could collect tumor cells and then solidify wherever your biopsy was or wherever the weak bone was, and I know there's different people looking at cementoplasty, cryoablation. So the short summary is, if you could get enough cells from that collection, yes. Other tumors that they've done: skin, soft tissue, muscle, spleen. Yeah, you can remove part or all of an organ and make a vaccine out of it. It's really just the viability of the cells. Yeah. I'm always really leery of studies that remove part of a bone tumor and then have those dogs live with that painful process. I did quite a bit of pain research at the University of Missouri, and the similarity I can give people of a bone tumor growing or a metastatic tumor to bone growing is if you ever hit shins with another person playing soccer, field hockey, or in the Midwest, all of us have hitches on our trucks. If you've ever run into a hitch with your shin, that excruciating periosteal pain that you hit when your bone hits another really, really strong object. And so for me, I always worry about collecting stuff and leaving a leg on that's that painful unless you can adequately control pain. I know there's other people that do that, but it always makes me quite leery. The study schedule for this is similar to the initial standard of care arm with NIH. And so dogs are screened with chest x-rays, ultrasounds. They get baseline blood work. And then we do, like I said, an amputation. Their tumors are confirmed on histopathology. We're using VDX as the laboratory for this. And then their vaccine is prepared by Ardent. And so if they clear those things, they're randomized, and then they go every 3 weeks, this for immunotherapy, and we're monitoring them every 2 months thereafter. Same thing for the carboplatin, every 3 weeks, but 4 doses instead of 3. So it's 3 doses of vaccine for the immunotherapy arm. The vaccine schedule, and Mary, you asked this, how does it look? So it is intradermal, and we put the checkpoint inhibitor in the dorsum, and then the vaccines go over draining lymph nodes. This is similar to what Elias did in their ECI studies. And I have a couple of videos, sorry, I try not to sneeze. I have a couple of videos of me administering these vaccines to a dog in a commercial setting. And so there is a priming dose of the checkpoint inhibitor, and then a day of dose checkpoint inhibitor plus tumor vaccine. And so you can see that's repeated 3 times on those back-to-back days. So I hope these work. So this is a dog that we were treating in Maine when I was doing part-time relief work up at Maine Veterinary Medical Center in VMC. So this is a little VaxID applicator. It actually allows you to give vaccine intradermally without a needle attached to the end of the syringe. And so it actually just collapses down on itself. You make contact with the skin, and then it puts a little bleb into the skin. Hopefully nobody's squeamish, but it is just a little almost TB poke, if you will. And you can see this nice bleb of where that infused. And so this is a 1/2 ml syringe. We do 2 of these. I lost that there, I'm sorry. We do 2 of these 1/2 ml injections. This is the CD200 itself. So now they're gonna go side by side, I'm sorry, but you can actually see the previous bleb on this dog, and this is intradermal. So it's similar to a TB test. If anybody's ever got allergy testing, it's similar to that. It's an infusion, small amount. You can see the googly eyes here, I call them, of 2 intradermal injections into the back. The autologous vaccine is a bit gooier. This is live cell vaccine, and so you can see here it's kind of red or tinted of dead cells versus the checkpoint inhibitor, which is a peptide. Let me mute these real quick, otherwise you'll have to hear my voice.
So this is autologous.
Autologous vaccine here, again, that VaxID applicator. We're putting the dose of the amputated leg next to the checkpoint inhibitor. And so if you remove, let's say in this dog had a femur tumor of the right hind, so his right popliteal dose goes next to his checkpoint inhibitors. And so you can see here, you make contact with the skin, inject the vaccine next to the tumors, and you have a little bleb. There's just a tiny amount of leakage there next to those checkpoint inhibitors. And so now you have checkpoint inhibitor right next to the autologous vaccine. Hopefully then all the schematics I showed of the little cartoon immune cells are active in that little area. I think this is muted. Okay, good. This is actually going now over the superficial cervical or prescapular lymph node. And so, we've made contact with that lymph node, injected. You'll see a little bleb here now over that draining lymph node. So the goal is to then have those dendritic cells and other T cells communicate with other draining lymph nodes in the area, kind of move across the body to promote immunosurveillance. The outcome measures that we're monitoring in this study is mainly disease-free interval. I talked about remission duration in these dogs. And so that is amputation until time to tumor progression. We're monitoring with chest x-rays, but we're also allowing ultrasounds if necessary based on clinical signs. And then adverse event reporting is through VCOG. That's standardized for our veterinary oncology community. And then the immunologic adverse events, we kind of mentioned this earlier. Chemotherapy adverse events in the chemo arm are mainly bone marrow suppression and GI upset is what we would expect. The study sites, University of Illinois and University of Wisconsin. I mentioned Maine Veterinary Medical Center. And then we have kind of a collection of corporate participants with clinics around the country, Ethos, Blue Pearl, and Thrive. This is, someone had asked about where are these clinics at. So this is the link. Ardent has a link on their website for the clinical trial. And then we have a page posted on the AVMA. Usually the AVMA will have all clinical trials available in the country. And so this is the landing page through the AVMA. So hopefully you can see those. If you just Google AVMA clinical trials, it'll go to the landing page, and then you can search for osteosarcoma specific trials around the country. But I think we're now open at 16 or 17 specialty hospitals around the United States. The trials team, I mentioned Tim Fan at the University of Illinois. Myself, Adrian, is the sponsor representative from Ardent, and then Marissa Kroll is our lead study monitor. She's been really great for the study data. And then we're, like I said, we're using VDX Laboratory for histopathology. They have a great group of pathologists that's reading out our osteosarcomas. My acknowledgments, a lot of this stuff was research I participated in or led when I was at the University of Missouri, and then some stuff at Penn. And so I just have my groups here, my Mizzou group, Amy LeBlanc's group at the NIH, the radiation bisphosphonate research that we did, some osteosarcoma work I did with Andy Flory at PetDX. Here's Tim Fan at the University of Illinois, and then one of our patients with osteosarcoma going through CHOP, or sorry, that was Penn Med, I guess, at University of Pennsylvania. So just a thank you to everybody that helped me along the way when we're researching osteosarcoma. And I think that's what I've got now, and I'm probably at my time. So other questions, thoughts, anything else, Mary, that the group would have? Yeah.
Let me see. There's a list of, you showed us the clinics. I'm going to share, we made a map. I hope this is correct.
Good.
Can you see the map?
Oh, yeah.
Yeah. So we have one in Tacoma, I think, close to Seattle, and then Southern California. You guys are in Denver, Kansas City, Wisconsin, Pittsburgh. There are quite a few clinics. So,
Yeah.
but this clinical trial is not going to be open indefinitely. You're going to enroll a finite number of canine patients and then close and analyze the data and try to get approval
Yeah, that's the
next year,
hope.
right?
That's the hope. Yep. Is we show non-inferiority. Hopefully, that the best thing would be superiority. But if we show that we're similar to chemotherapy alone, it would then be available. And then, like you said, can we combine it with chemo or other things to make it even better? That would be the next step. Yeah.
Yeah, yeah, that's fantastic. Let me see. Do we have any other questions? I don't know if you saw this poster from Professor Mamula and Professor Ron Sellen from Washington State University.
Yeah. Yeah.
So, Washington State University has enrolled some patients with osteosarcoma who are not candidate for surgery, and they received EL vaccine, and they had palliative radiation and
Yep.
zoledronate. And palliative radiation, if you do it right, could act as in situ vaccination.
Yep.
So it could act similarly to autologous vaccine. So I'm curious, maybe in future, that's something that might be worth looking at.
Yeah, we've Charlie Mites is the radiation oncologist at Missouri, and he and I were resident mates and then faculty mates. And there's a cool pathway called T-Rex, and we both love dinosaurs, and so it was just kind of a fun pathway name for us. But yes, we actually did some of those studies. We just got accepted a brief research report for some work we did in melanoma in dogs about combination radiation plus different immunotherapies. And so Colorado State is really getting after the research in that. We were doing some at Penn. Yes, the answer is yes. If you get the right dose, and usually it's under 10 or 12 gray. And so if you go too high with the radiation, you actually ablate all of the immune system. If you go too low, you don't excite enough. And so there is this sweet spot that's probably around 6 to 8 gray, where you can actually promote the immune system. And what I do in clinical practice, I mentioned Oncept earlier, that DNA vaccine from people for melanoma. I like to combine it with radiation so I can actually promote neoantigens, if you will, or if there is dog tyrosinase, that you can kind of break out, get the antigen presenting cells to show, and then recruit in the rest of the immune system.
Oh, that's fascinating.
But yeah, radioimmunotherapy is a
Mhm.
very hot topic in human medicine and has a lot of potential.
So what's the timing and which comes first with onset vaccine versus
That's the
palliative
best
radiation?
question. Yeah. So I've had that talk with Ahmed Mehdi is a radiation oncologist that was at Penn. He now leads Huntsman Cancer Center in Utah. And he and I talked about that a lot. I think there has to be a little bit of a prime, kind of like we did in this clinical trial where we're priming dogs with checkpoint inhibitor and then following with the vaccine. We talked about priming dogs with whatever immunotherapy you're going to do and then using radiation. There's also a really important part of if you radiate the tumor but also the draining lymph nodes. Because a lot of times if let's say a head and neck tumor is metastatic, it'll go to the lymph nodes next. But that's actually where the immune system is most active to try to say what's bad and what can I kill. And so if you radiate the lymph node, are you removing those good lymphocytes that you need there? So there's a lot of complexity. And what I would tell you is people are working on what's the ideal timing, and it probably depends on what the therapy is. But with checkpoint inhibitors and radiation therapy, especially, you don't want to ablate the immune system, I guess is the short answer I can give you, especially those tumor draining lymph nodes. Yeah.
Yeah. I heard from several researchers that if you do aggressively use radiation therapy, stereotactic or high dose radiation, that you could also draw in regulatory T cells that'll further
Yeah.
suppress the immune system. So
Yeah.
the low dose is the key to stimulating the immune system. That's
Yeah.
cool.
Moderate dose. Moderate dose.
Moderate dose. Okay, not too low. So then with for melanoma, combining immune checkpoint inhibitors like CD200 and oncept vaccine and palliative radiation
Yeah.
in future might help.
I would love it. And then you have to say, like, can we afford that stuff, right? So can we get stuff to be affordable? And
Yeah.
I have been excited about checkpoint inhibitor with onset vaccine. Phil Bergman and I have talked about that. I know other people, they're looking at that in human medicine. Could you combine radiation therapy with something like, gilvetimab or CD200 and the onset vaccine? Yes, 100%. And then you could, completely avoid chemotherapy, which is pretty exciting. The big thing though is the immune system has to figure it out, right? Like when we give chemotherapy, we're relying on chemotherapy to do the job. When we give these immunotherapies, we need the immune system to work. And so there's people also looking at, are there patients where the immune system is so compromised it can't figure it out? And could you help them? And so I think that's part of it too, is not all of our immune systems are created equal. And so how do you tailor it so that everybody's immune system could, for lack of better terms, wake up?
Can you just give us a summary, sort of comparing what PD-1, CTLA-4 checkpoint inhibitors do on their own versus CD200? Because CD200 is a little bit more complicated, I feel like.
Yeah, it is more complicated, and really, it's not one of the typical. Let me pull back up that slide, and I'll show you. So, if you look at this schematic, you're right. CD200. If I go back to this pathway, CD200 is a surface receptor that has its own receptor. This CD200 ARL actually is supposed to interfere with that communication. What I haven't seen, and it's so new that there's only a few labs studying it, what I haven't seen is how does it downstream block CD200, PD1, PDL1. And so the big difference is this is a peptide. So they have it here as like a little peanut, if you will. So it's actually a protein peptide versus these guys. Usually the checkpoint inhibitors are monoclonal antibodies. And so those monoclonal antibodies like gilvetimab are going to go in and they're going to actually block the binding because they're so specific to that receptor. And so the anti-CTLA-4 is a monoclonal antibody. It's still a protein, but it's an antibody itself that blocks the interaction of these two. Same for PD1, PDL1. So gilvetimab is going to go in and block this canine PD1. And so the CD200 is different in that it's its own little peptide. It doesn't have that monoclonal antibody motif, if you will. And I think the only other image I have is of this one, if it'll go. But if you see down here, this little bitty guy, it's the little Y that we talk about, the antibody itself. It'll block PD1, PDL1, CTLA-4. And those monoclonal antibodies have their own problems with clearance, with distribution, and then with potential side effects. And so the novelty of the CD200 is it's a peptide protein, not a monoclonal antibody. And its pathway may interact with those other checkpoint inhibitors, but usually is through dendritic cell enhancement and cytokine production versus going after a don't eat me signal on its own. Hopefully that helps.
Do you think you're going to be offering booster shots? So a
Yeah.
year later?
Yeah, I can tell you that commercially, especially dogs that live a long time, we booster Oncept as a DNA vaccine. And I don't want to jinx these patients, but I know of a couple of dogs that are getting boosters. The problem is you have to have enough vaccine prepared and saved. And so these tumors are pretty big osteosarcomas, and you have to have enough cells to make a live cell vaccine. And so in theory, then, we have 3 shots. You'd have to have another 4th, 5th, 6th. So they have to have a lot of tumor to be able to make all those vaccines. Yes, the thought would be is could you booster in the future? Right now, the technology is because it's autologous, is you have to have enough vaccine from the tumor itself. I could see in the future, could you engineer it? Probably if we talked in a decade, maybe AI is making all of our cancer vaccines for us. Yeah.
I think the advantage is this is probably going to be less expensive than existing
Yeah.
antibody-based checkpoint inhibitors.
Yeah, and I don't hold the keys to any of that stuff, but I have a feeling this would be way more economical than some of our other immunotherapies. Yeah.
Thank you. No, this is really great. We learned so much. So, how long do you think the clinical trial is going to be open for? It depends on the enrollment, I guess, speed, but
Yeah, we actually we've really picked up. We've screened almost 30 dogs now, and I think we're close to 15 that are randomized. So remember, we had they have to have osteo and they have to have a vaccine prepared, and they can't have other exclusionary things. And so I think we're up to almost 15, 60 dogs is in the randomization scheme. So we're getting close to being a quarter of the way through. We opened in February, but we really didn't start to pick up until April, May, June. So my brain says if we're like, a quarter of it, through a quarter of it in 3 months, I don't know. I could foresee us being done by the spring with 60 dogs. Yeah. We want to enroll quickly, but yeah, I want people to have it available. And so the goal is, yeah, if we do have really promising data, we can get to the USDA quickly. Maybe we do have conditional approval that we can now offer it other ways. So, yeah.
awesome. And the AVMA Clinical Trials Registry has all the information.
Yep.
Okay,
Yep.
awesome. Great. Well, thank you so much. This is super
Yeah.
exciting.
You're welcome. Thanks for having me.
Yeah, and you've done so much already with so many trials, with Elias trial.
Yeah. Clinical trials is one of my passions, clinical research, especially in osteosarcoma. So yeah, we've done a lot, but we need to improve. We got to figure out how to do better. And I think it's funny. I go back to that stuff from the 80s, and Dr. McEwen had a lot of it on the right path. And so I think we just need to. The problem is what's available. What do we lose licenses for? Expenses, and so I think economical stuff, multimodality, and really understanding osteosarcoma's biology are keys.
I think if you have time, I'd love to chat a little bit about Miramil tripeptide some other time because
Yeah, I'd
it is,
love.
we found a place where you can order them from.
Yeah, get us a stash. I'd love it.
Yeah, yeah.
Yeah,
I know there are some people have stash in their
yeah,
freezer at
yeah,
universities, but
yeah,
regular
yeah.
people can't access that. So we want to figure out how to make that available in the US for
Right.
veterinary use. So, all right. Thank you so much again, Brian.
Yep, yep. You're welcome. Thanks for having me. Thanks everybody for coming.
Okay.
Bye.
Bye,
Bye.
everybody. Thanks.